Hello everyone. Our module is about diabetes, and I will be mainly talking about the relationship between diabetes and the mental health condition. First, we will go to what all psychiatric aspects commonly we see along with diabetes. First one is delirium. Next, substance use disorder, mainly tobacco and alcohol. Then mood disorders, anxiety disorders, schizophrenia and other psychotic illnesses. And you can see other types of illnesses also along with diabetes. First, we will talk about delirium. What do you mean by delirium? Delirium is a condition where there is a altered sensorium along with disorientation to time, place, and person. So, delirium can be a feature of underlying systemic pathology. For example, infection of meningitis, encephalitis, or systemic metabolic abnormalities can cause delirium kind of picture. Here, in alcohol, diabetes, delirium can be due to diabetic ketoacidosis, and also it can be due to hypoglycemic attacks. Similarly, in psychiatry, delirium can be because of alcohol withdrawal. So there is an overlap between the delirium between diabetes and psychiatry condition in terms of delirium. And also, what happens is there is a delirium in a patient with diabetes. It is associated with various adverse outcomes like increased hospital stay, increased cognitive and functional deterioration, mortality and increased morbidity. And delirium can be either hypoactive and hyperactive. So, what are the features of delirium? As you can see here, it can be a manifestation of hypoglycemic attacks or diabetic ketoacidosis. It can be hyperactive, hypoactive, or combined, and it's a very life-threatening condition with high mortality rates. So, early identification is very crucial, and you have to correct the underlying causes. For example, if it's hypoglycemia or ketoacidosis, it has to be corrected, and the patient has to be monitored closely and supervised, and supportive care has to be given. And at times, when the patient is very agitated, low dose antipsychotics like haloperidol will help the patient to settle down and calm the patient down and help them with reducing the agitation. Normally, it is very much seen in patients who are in ICU setups, and there's a feature called sundowning phenomenon, in which what happens is due to the when the day ends, there will be increased chances of disorientation. How do you assess that? Using the mental status examination or status examination scale. So I told you about hyperactive and hyperactive. Hyperactive is where the patient is excited, talking irrelevantly, and the patient is moving around aimlessly. And also we have seen in hyperactive they tend to be having this searching behavior in the middle of the night. They will be getting up and going around here and there. They can have hallucinations. They can look at something which is not there and talking to themselves. They can be searching for tobacco, especially which happens in alcohol withdrawal, delirium. And in hyperactive, it's the opposite, where they tend to be dull and they can have reduced psychomotor activity. And like I told you, disorientation, confusion, altered sensorium is present in both the hyperactive and hyperactive. So they can have visual hallucination, that is perceptual disturbances, sleep-wake cycle disturbances. So what happens is in the morning they can have daytime drowsiness, followed by night they can have sundowning phenomena and increased chances of delirium. And thought disturbances can also be seen. And it can be fluctuating with waxing and waning periods, interspersed by lucid intervals. So, like I told you, early identification is very important. Mainstay of treatment is treatment of the underlying cause, and low dose of antipsychotic can be mixed by therapy. Coming to the next condition, psychiatric condition, which will affect the outcome of diabetes is tobacco. Tobacco can be either smokeless or smoking. Smoking is mainly bidi, cigarette, and hookah and cigar, whereas smokeless is gutka, chindi, and snuff. All these things are and smokeless tobacco fat. So, cigarette smoking is an independent and modifiable risk factor in developmental diabetes. So, those who smoke have more chances of getting diabetes rather than people who don't smoke. And also, it can increase because diabetes as such can cause diabetic nephropathy, diabetic retinopathy, and neuropathy. Cigarette smoking also can cause peripheral vascular disease, which can lead to nephropathy, retinopathy, and neuropathy. And there is an increased risk of microvascular complications like coronary heart disease, stroke, and peripheral vascular disease. Then, in smokeless forms of tobacco use, they can have more in diabetic people who are taking smokeless tobacco are more prone for severe periodontal conditions, and they can have more infections of the mouth, like candidiasis, etc. Uh, what what are the hypotheses which says tobacco uh, makes them more vulnerable for diabetes? One is smoking induced hyperglycemia. Secondly, hyperinsulinemia and elevated blood pressure. Smoking induced impaired liver function. Pre-diabetogenic action of components of tobacco smoke. Example, cadmium. These are some of the hypotheses which are known to, which are implicated in causing diabetes in tobacco users. So another important issue about tobacco smoke, which contains nicotine and other chemicals, is a inducer of CYP 450 system. It's an enzyme inducer in liver, which can induce or inhibit certain drugs, especially anti-diabetic drugs. So, person who is smoking and also on diabetic and on anti-hypoglycemic has to be supervised along the lines. The next thing is smoking cessation. What happens with this when they stop smoking? It can facilitate a good glycemia control, and it can limit the development of diabetic complications. And also it will limit the microvascular and macrovascular complications. So how do you make the patient to stop smoking or stop using tobacco? It is through nicotine replacement therapy. That is what NRT means. Nicotine replacement therapy, where we tend to use agents like nicotine chewing gums, nicotine patches, which will help the patient to stay away from the smoking or chewing tobacco. And there are certain drugs like bupropion, epinephrine, and clonidine. All these drugs also they decrease the craving for tobacco and then keeping them abstain from the tobacco use. Coming to the next psychiatric comorbidity, uh, that is alcohol. So, in a diabetic population, around 50 to 60% people use alcohol. So that's quite a high number. If there are two diabetic, one will be taking alcohol, and so on the other hand, alcohol consumption can also increase the risk of type 2 diabetes. So what happens is when the person takes alcohol, it can induce pancreatitis, and which can lead to glucose intolerance. So, so how does it cause hypoglycemia? There are certain what happens is when people take alcohol, they are more prone for hypoglycemic attack, especially people who are diabetic and on hypoglycemia and anti-diabetic medication. So one of the mechanisms is alcohol-induced fasting hypoglycemia, because usually patients who take alcohol tend to take it in empty stomach, so that can lead to fasting states and hypoglycemia. Second is potentiation of drug-induced hypoglycemia. Third is reactive hypoglycemia and susceptible anti-nutrients. So hypoglycemia, what happens is when there is hypoglycemia, they can have sweating, they can have palpitation, they can have giddiness, they can have in severe cases seizures also. So what else can happen with alcohol and diabetes. One is heavy alcohol consumption can increase the risk of diabetic ketoacidosis, peripheral neuropathy, and retinopathy. And also, alcohol consumption is inversely associated with adherence to diabetic self-care behavior. What do you mean by diabetic self-care behavior? So, persons with diabetes, they need to follow certain lifestyle modification, like poor proper diet control, good physical exercises, and taking care of their wounds or food care. All these things has to be done very meticulously. But when there is alcohol consumption in the range of dependence, then it can impair the self-care behavior of the diabetic patients. So that can lead to further mortality and morbidity. It also can cause weight gain and elevated glucose levels. So weight gain and metabolic syndrome is directly related proportional to the diabetes in an individual. So, and another thing is alcohol can alter the metabolism of oral hypoglycemic agent. See, here I am talking about various psychiatric illnesses and in relation to diabetes. So, before going into the management, I would like to talk about dependence. When do you call a person to be dependent on a particular substance? There are mainly 6 criteria. The first criteria is craving. Craving when there is an intense desire to consume a substance. Second is tolerance. Tolerance means the person takes the substance and after a while the person will not get the same desired effect. So the person tend to take more and more of the same substance. Then withdrawal symptoms. In withdrawal symptoms, when the person abruptly stops the substance, can lead to withdrawal symptoms. For example, in alcohol, the persons can have tremors, palpitations, anxiety, sweating, autonomic hyperactivity, then delirium tremens, and seizures. So if you see, if you overlaps with multiple many symptoms of diabetes. For example, diabetes itself can cause delirium through, like I told you earlier, diabetic ketoacidosis or hypoglycemia, and even hypoglycemia induced by oral anti-diabetic agents can also lead to seizures. So one thing you need to be aware of. So that's the third criteria, that is withdrawal symptoms. Fourth being loss of control. So the person want to drink in a certain quantity but end up taking more due to the lack of control over the use. Fifth criteria being salience, where the person will give priority mainly to the substance rather than the other important issues in the patient's life. For example, skipping day-to-day functions, skipping major responsibility, not helping the family financially, just for the sake of using substances. Then the sixth criteria being uh, use of the substance in spite of harm. So that means, for example, in alcohol, long-term use can cause alcoholic liver diseases characterized by cirrhosis, ascites, jaundice, all these things. But the person might not want to stop in spite of having these serious consequences. So we say a person is dependent when person meets at least one or two criteria for the last 1 year. So how do you manage alcohol? There is a questionnaire called CAGE questionnaire, which assesses the severity of alcohol use. Then non-pharmacological intervention like brief intervention, motivation enhancement therapy, self-group like such as Alcoholic Anonymous has a great role in managing alcohol addiction. Whereas coming to pharmacotherapy, every alcohol dependent patient needs to go through certain processes called detoxification and de-addiction. Why detoxification is important? Because like I told you earlier, when the person takes alcohol for a long period of time, they can develop tolerance. What you mean by tolerance is they develop certain changes in their brain homeostasis. So if the patient abruptly stops alcohol, they can have withdrawal symptom. So what you do in detoxification is you substitute with the drug which acts similarly like alcohol, then slowly tapering off the drug. So in alcohol management, we use drugs like benzodiazepine, like diazepam, chlordiazepoxide, and then we slowly taper it off. Once they are tapered off, subsequent motivation enhancement therapy, along with anti-craving or aversive agent. Anti-craving agents like baclofen, naltrexone, topiramate, all these things can be used for reducing the craving. Whereas aversive agent is mainly disulfiram. One thing to note down here is disulfiram. When we start, the patient needs to give a consent for it, and the patient has to be explained about the disulfiram-like reaction, which is characterized by sweating, redness, palpitation, vomiting, diarrhea, and even sometimes death. One thing you need to remember here is certain drugs like anti-diabetic drugs can cause disulfiram-like reaction when taken with alcohol. That is one more important issue you need to remember in relation to diabetes. Coming to the next category of psychiatric illness, mainly mood disorders. So mood disorders, when we talk about mood disorders, what do we mean by mood? Mood is the current emotional state. So mood disorders are mainly what we see is unipolar depression, which we commonly see. Then bipolar affective disorder, where there are episodes of depression, and then mania or hypermania or mixed episodes. Then dysthymia is a low grade of depressive symptom which does not fulfill all the criteria of depression. These are some of the important mood disorders. How is it related to diabetes? So, the prevalence of diabetes is very high in patients with BPA. So, what happens when there is a mood disorder along with diabetes? It is associated with increased complications, mortality rate, and increased healthcare cost because the patient tend to be admitted both for diabetes and also for the bipolar disorder. And what happens also is in bipolar disorder, especially chronic bipolar states, they can develop certain cognitive deficits, which can lead to poor lifestyle modification like poor diet, habitual inactivity, excessive nicotine use, and also the important thing is psychotropic medication. Whatever the medication we use for management of bipolar disorder tends to cause metabolic syndrome, that is weight gain and poor glycemic control and obesity, which can lead to increased risk of diabetes. But then the question is, should we not use the psychotropic medication? So what we do is we have to weigh the risk and benefit. Some of the agents, if the symptoms are very high, we need to take the risk in order because the benefit outweighs the risk. The other thing which we can do is there are certain drugs like aripiprazole or like oxcarbazepine, which is weight neutral. So these kind of drugs can be used in management of bipolar disorder. And like I told you, all antidepressants also have been associated with increased risk of diabetes. Like I told you again, mood stabilizers and antipsychotics used in the management of bipolar disorders can cause metabolic syndrome. So, and lithium and valproate, they are associated with weight gain and impaired glycemic control. Again, sodium valproate can also cause pancreatitis, hepatitis. So that can also lead to make the patient more prone for developing diabetes. So coming to depression, so in bipolar disorder also the patients can have depression, which is bipolar depression. Management differs slightly in cases of bipolar depression, whereas depression, what we usually discuss is unipolar depression. It can be reactive, that is exogenous depression, it can be endogenous depression. Exogenous depression means which is due to some external factors. Endogenous depression means due to some internal factors. So depression and diabetes, they share a bidirectional causal association. So what I meant was in patients with depression, their the risk of developing diabetes is around 50 to 100%, than the normal population. And similarly, diabetes has been known to be depressogenic, means it can itself cause depression in patients who are not depressed previously. So how can it cause depression? I'll talk about it later. So, and what happens is if a person has both depression and diabetes, what's big data about it? It can is associated with increased mortality, increased morbidity, and functional impairment, greater functional. So, what can cause depression in a patient with diabetes? So, it is based on biochemical, psychological, and behavioral factors. Biochemical factors such as hypercortisolemia, which is secreted in response to stress, which can be due to having diabetes or some other factors. Leptin activity in limbic system, altered glucose transportation, and pro-inflammatory cytokines. So in a diabetic, these things can cause a person to develop depression. Psychological factors means, like I told you, stress associated with living in diabetes, poor treatment adherence can lead to more risk of depression. Behavioral factors like sedentary lifestyle, smoking, and overeating can lead to more further risk of depression in diabetic individuals. So, what are the symptoms of depression? First, there are three major depressive symptoms. First one is feeling sad or sadness of mood, and then loss of interest in their favorite activity, which is also associated with anhedonia. Anhedonia means loss of pleasure in previously pleasurable activity. Then, what else? Fatigue. They can have lack of energy. That is the major three criteria, followed by either eating more or not eating at all, either sleeping more or not sleeping at all, having trouble concentrating and making decisions, feeling tired and fatigued, feeling hopeless, irritable, anxious and guilty, feeling worthless, helpless, and suicidal thoughts, having aches and pains, cramps, digestive problem, loss of libido. All these things can be seen in person with depression. One thing you need to know is elderly where you also see diabetes, depression can be only seen in terms of having anger and irritability. There are no other symptoms of depression do not come through. So that is one thing you need to be mindful of. Coming to the next category of psychiatric illness, that is anxiety disorder. Anxiety disorder means uh, the group of illnesses which is characterized by anxiety attacks, which has both psychological and physical component. One of the common anxiety which is usually seen along with diabetes is generalized anxiety disorder. So what happens in anxiety? Anxiety means a keyed up state where there is a sympathetic overactivity, flight or fight reaction. So in those states, the person has more stress. That is the lead to chronic stress leads to increased chronic cortisol levels, which can lead the patient, which can make the patient more prone for developing diabetes. That is what we see in, these days. We see a lot of lot of younger people getting diabetes because of the anxiety and stress related to the work. There will be a lot of stress related to the work, and they develop diabetes at a very young age group, along with their sedentary lifestyles. So, the prevalence of anxiety disorder among patients with diabetes is considerably higher compared to the general population. The prevalence rate of generalized anxiety disorder has been found to be three times higher than that of the general population. So, what do you mean by generalized anxiety disorder? It's a group of illness where there is the patient tends to be very obvious. There is like a free floating anxiety, a cloud of anxiety over their head, and they worry about each and everything about their life. So that makes them more on edge, anxious, and they can have sympathetic hyperactivity, body aches, and they can be edgy. So this can lead to more risk of diabetes. So anxiety symptom also Uh, like I told you, this can cause more, make the person more prone for that. One more important and interesting thing we need to know about anxiety disorder. One is needle and injection phobia. Phobia means a group of illnesses where there is irrational, excessive fear, which is also to a, to a certain stimuli associated with avoidance behavior. So, needle and injection phobia, the patients are extremely fearful about getting an injection, or they are fearful about the needles. So in diabetic patients, especially in late stage diabetes, where there's a need for insulin injections, these patients have difficulty if they have needle phobia. So they tend to miss out on glucose monitoring. Also, they need to check their glucose repeatedly, and also they can avoid insulin dose administration in severe cases. Second interesting thing is about phobia of hypoglycemia at glycemic episode. I'm sure most of us might have had hypoglycemic episode once in our lifetime when there is intense uh, anxiety, palpitation, sweating, something bad is going to happen. So, what happens is it can be reactive hypoglycemia, or it can be in persons with we see hypoglycemia in patients with insulinoma, or in patients with diabetes. If they are taking insulin, they can also develop hypoglycemic episode. So, if the patient has a phobia of such episodes, they may try to maintain a chronic state of hyperglycemia because of fear of developing a hypoglycemic episode. And like I told you, the hypoglycemia can present with sweating and palpitation and anxiety. Similarly, in panic disorder and also in other anxiety disorder, the clinical features will be mainly sympathetic overactivity. That is a physical component of anxiety, which is sweating, anxiety, tremor, and tachycardia. And psychological component of anxiety is mainly fear, anticipatory anxiety, feeling of doom, that something catastrophic is going to happen, that I'm going to die. These are the psychological component of anxiety, which both of which can be present in even hypoglycemic episode. So, in a diabetic person with anxiety disorder, it is very important to differentiate which is causing these symptoms. And also, in a patient who is chronically anxious, they might have got used to their anxiety symptoms, so they may tend to miss out on hypoglycemic episodes. Again, one more important thing is whenever there is an anxiety patient, we tend to use beta blockers like propranolol. Propranolol tend to block the sympathetic overactivity, so it can also mask the symptoms of hypoglycemia. So that thing we should be aware of and careful when we are giving a beta blocker to a anxiety patient with diabetes. So the medication, what we use for anxiety disorder like SSRI, benzodiazepine, they can also interfere with the glycemic control. Coming to the last group of illnesses like schizophrenia and other psychotic illnesses. Schizophrenia, one thing is there is a risk overall in schizophrenia it is 2 to 4 times more risk of developing diabetes than in general population. And with diabetes and schizophrenia, higher mortality rates and there is higher morbidity and also higher hospital admissions. Uh, so what happens is schizophrenia is associated with impaired glucose tolerance and insulin resistance. So mainly two important things which you need to know is first one is what we give for schizophrenia, especially antipsychotics like the olanzapine and clozapine. They tend to cause a lot of weight gain, metabolic syndrome, and also hyperglycemia. So especially atypical antipsychotics like risperidone, olanzapine, clozapine, quetiapine, all these things can cause can increase the risk of diabetes. The second important thing is because of their schizophrenia and negative symptoms, they tend to be poorly motivated to take care about themselves. So they can be physically inactive. They might have a poor dietary habits, poor health care, and treatment of So this can lead to further worsening of the underlying diabetic complications. Especially negative symptoms, they tend to avoid their self-care will be very poor. So they might not monitor their diet, and the physical activity will be very minimal. So that can lead to, we have seen many schizophrenia patients with diabetes going in for complication like diabetic foot and gangrene and amputation. Along with that, one more very important thing is in schizophrenia, the patient usually lacks insight about the illness, so they tend to stop medication. So when they stop anti-schizophrenia medication, they also tend to stop medications for diabetes. So that can lead to further worsening of the both conditions and leading to more complications. So this is in brief about some of the common psychiatric conditions and its relationship with diabetes. I hope you understood all the things. Any doubts? Let me know. Thank you.